Hello, my name is Dr. Jeff Zobel. I'm a pediatric clinical pharmacist at a children's hospital in Arizona, as well as a clinical support liaison for MVW Nutritionals. And it's my pleasure, along with my colleague, Dr. Kevin Epps, to present the second part of our webinar series for MVW Nutritionals, CF Nutritional Update. I have 18 years of clinical pharmacy experience in the cystic fibrosis space, having worked since 2006 at a CF center in Salt Lake City, Utah, as well as in the CF space, taking care of patients for the last, both inpatient and outpatient, for the last 18 years. The only disclosures that I have is I'm a clinical support liaison for MVW Nutritionals, providing education for CF patients and families, as well as care centers in this era of highly effective modulators. The objectives of our presentation today are to discuss nutritional clinical quandaries of CF care in the era of highly effective CFTR modulators, as well as explain the clinical rationale behind modifications in CF-specific vitamin needs in the era of highly effective CFTR modulators. Our first clinical quandary relates in nutrition is looking at the BMI percentile category distributions from the most recent 2022 CF annual data report that was published at the end of 2023. As we look at the categories for BMI percentiles of both pediatric ages 2 to 19, as well as adults ages 20 and above, we look at the different categories that have been distributed from the CF Foundation registry for the last from years 2012 to 2022. Mainly looking at the light blue and light green categories, which are at the top of both of these graphs, which are considered BMIs between 86 and 95 for the light blue and BMIs greater than 95% for the light green. When we look at what's happened since 2019 in both of these categories, since the release of elexacaftor, tezacaftor, ivacaftor, we see a significant increase in both the overweight and obese categories for these patients in the BMI areas. Specifically in the adult category, ages 20 years and older, we see a large increase, especially in the light blue categories in the last 2 years from 2021 and 2022 after patients being on ETI therapy for at least 2 years. So when we look at the CF Foundation registry data as well as the literature information even closer, we find that over almost 65% of CF adults are now at the CF Foundation BMI goal, as well as 13% of CF patients are considered in the obese BMI category. And that percentage of CF adults overweight or obese have more than doubled since 2001. There are also several case reports that have been published looking at patients who have converted from pancreatic insufficiency to sufficiency. And most recently, there are 2 case reports of patients on ETI therapy, both 2 in adult and 2 pediatric patients who have converted from pancreatic insufficiency to sufficiency. Previous to this, it was only reported in ivacaftor as well as lumacaftor ivacaftor patients. Recent studies have also shown there's a decline in enzyme utilization in patients who are using ivacaftor in registry data studies from both Germany and the United States. Also looking at surveys from patients, from CF patients and providers showing decreased enzyme utilization as well as acid suppression therapy. Those doses have decreased in patients who are on highly effective modulator therapy. So when you look at these clinical quandaries, the question would be, what do you do in this era when you're seeing in the obesity and patients are increasing their weight with their BMI, as well as patients who are having maybe converting from insufficiency sufficiency? How do we address these as a CF population and CF center providers? So there are a few articles that have been published that may be able to help in this area. Number one was an article that was published by Gable and colleagues back in 2022 with a group of CF dietitians and providers that offers some suggestions to be able to answer this clinical quandary. It talks about in this article that CF providers need to start the conversations about what's going on with the patients, exactly what's happening to their bodies, and so they have a better understanding of exactly what to do. Also, it outlines motivation interviewing techniques, how to work with the patients, and how to address these issues. It provides individual nutritional approaches in the article, as well as resources about exercise and diet, healthy diet options for these patients. It also does talk about medication intervention techniques for overweight and obesity, such as bariatric surgery and semaglutide. Another article that was published specifically by the CF Foundation by Leonard and colleagues addresses the nutritional considerations in this new era highly effective modulators, a CF Foundation position paper that actually goes through different techniques and areas that the care teams can actually address, looking at what the patients and families can do, the dietitians, then the roles that they may have in weight management, as well as food insecurity assessments. It addresses what the social worker and clinical psychologist, mental health coordinator can do, the pulmonologist and other providers in the clinic, such as advanced practice providers from the pulmonary side, as well as gastroenterologists and endocrinologists, and what they can do to help the patients. It also addresses what the nurses can do as physical therapists, and pharmacists is also listed in this position paper, looking at what they can do to assess drug nutrient and drug-drug interactions, including weight loss medications for these patients, and what they may have to do to help the patients to address this clinical quandary. Our second nutritional clinical quandary is associated with vitamins, specifically the CF-specific vitamins A, D, E, and K, and what's happening to them in this era of highly effective modulator therapy. When we look at the information from the CF registry, we find that almost 90% of patients are on CF-specific vitamins due to the fact that almost 90% of patients are pancreatic insufficient, requiring enzyme therapy as well as vitamin supplementation. Recent studies and case reports have been published showing the need that was happening in this era, that vitamin levels are increasing due to the fact of possible better absorption from the highly effective modulators, as well as toxicity, specifically vitamin A toxicity in patients taking CFTR modulator therapy. When we look at these studies, we find that they are ranging of what happens with the vitamins. And so 2 studies were done with lumacaftor or ivacaftor, where in patients, the first one by Sommerberg and colleagues showed that vitamin A levels increased significantly 2 years post starting lumacaftor, ivacaftor in patients, but vitamin E levels actually decreased significantly in those patients. A study that was published in 2023 by Gachenard and colleagues showed that the median vitamin E levels actually increased in those patients post lumacaftor, ivacaftor therapy. In a study by Brittany Wright and colleagues out of the University of Iowa, looking at elexacaftor, tezacaftor, ivacaftor, showed that vitamin D levels actually increased in patients after starting ETI therapy. in two studies that were just recently published in 2023 shows some interesting information regarding all the CF-specific vitamins, particularly vitamin A. And when you look at these studies by Schembri and colleagues and Roeder and colleagues, they both show significant increases in the median vitamin A levels in both of these patient populations. Some of them showing patients having high vitamin A levels, and both giving recommendations that vitamin A should be routinely monitored after starting ETI therapy. In the Schembri and colleagues, they recommend that vitamin A levels should be recommended that be checked at least 3 months post starting ETI. And in the Roeder and colleagues, they say check routinely because of the significant increase in vitamin A that was shown per year starting ETI, at increasing of almost 41 micrograms per liter. In both of these studies, there were no changes in vitamin D or E in the Schembri and colleagues, or there was only a change in the vitamin D in Roeder, but in that study, vitamin E did not significantly increase, or no changes in INR. In the Patel and colleagues study that was just published in early 2024, there was, by a group out of Cleveland Clinic, showed that post-ETI therapy, vitamin A levels went up almost 8 micrograms per deciliter, as well as an increase in vitamin D, with no significant changes in vitamin E. The reason why vitamin A is probably the one that is the most concerning is from the studies, but we also have one case series and one case report of patients having increased vitamin A levels as well as increased vitamin A toxicity associated with the vitamin A level after starting ETI therapy. The first case series by Miller and colleagues showed 2 cases of papilledema due to increased intracranial pressure. And papilledema is an increased intraocular pressure and pressures on the retina and the back of the eye. So of the first case was a 12-year-old female who had, upon diagnosis, was a late diagnosis, had a low serum vitamin A level, was then started on CF vitamin supplementation, which then increased that vitamin A supplementation to 4 capsules a day, which then led to a level going up to 23 micrograms per liter. The patient then started on ETI therapy. 2 months later, started having symptoms of headache, nausea, and then went in for a routine eye exam showing bilateral optic disc edema. The patient reported blurry vision. The team then checked a serum vitamin A level, which was found to be 58 micrograms per deciliter, which was slightly elevated, but in 2 months it increased from 23 to 58. They reduced the CF vitamin supplementation. They started a medication called acetazolamide, which can help decrease intracranial pressure, and the papilledema started to resolve. In the second case of this case series by Miller and colleagues, showed another 12-year-old female was a late diagnosis, actually had a serum retinol level, vitamin A level that was 45, which was near the upper limit of normal upon diagnosis, and was only on a pediatric multivitamin. The team started ivacaftor for this patient since the patient had mutations that were eligible for ivacaftor. The patient did not do well clinically, so then was changed to ETI therapy. They also increased the patient's CF vitamin supplementation to Aqueduct 2 tabs a day. 2 months after starting ETI therapy, the patient started having symptoms of intraocular pressure, intracranial pressure, headache, tinnitus, had bilateral optic disc edema. And the patient was diagnosed with elevated intracranial pressure. They did stop the CF-specific vitamins, and the serum retinol level was 48 micrograms per deciliter, which was within normal limits. They started acetazolamide. After 4 weeks, the headaches resolved, but the visual acuity was still impacted and the papilledema was still present. They increased the acetazolamide dose. 7 weeks after being diagnosed, the serum retinol level actually had increased from 48 to 57, which was only mildly elevated, even though the vitamins had been stopped. 15 weeks later, the papilledema did resolve, but the serum retinol level was 60. And even though there had been no supplementation for 15 weeks, the level continued to increase up to that point. In the other case, the report that we have by Wisniewski and colleagues was an 11-year-old female who was started on ETI therapy, but had vitamin A levels on this timeline, as you can see on the bottom of the slide. So the timeline showed over months the patient had every vitamin A level was subtherapeutic and was below the threshold. When the patient was started on ETI therapy, there was a large jump in the initial level, was still within normal limits, but the symptoms of intraocular pressure, increased intracranial pressure actually started before the patient had elevated levels. Then, not much after the patient had the diagnosis of the increased intracranial pressure and papilledema, the serum retinol level significantly increased after they had even stopped the CF vitamin supplementation. It took several months for the serum retinol level to finally decrease, as well as a resolution of the papilledema for the patient. So in this instance, what would you do as a clinical team, care team, to basically help this patient to address these issues in this era of highly effective modulator therapy? There are multiple options that can be provided by the team and what to do clinically. Number one would be to take the CF-specific vitamin that they are taking for the patient and modify the dosing. Either decrease the dose to a couple times a week and following levels, or to specifically take out the daily CF-specific vitamin and only supplement the vitamins as needed as individual vitamins. However, following levels may not be the most optimal way of taking care of the patient because, number one, especially pediatric patients do not like to have their blood levels drawn all the time. And then the levels when you look at the literature, there may not be a very good correlation between the level and the toxicities that we are seeing with the increased papilledema. So this is where we may have to think outside the box a little bit what we need to do for these patients. So MVW Nutritionals has developed a new formulation called the MVW Complete Modular formulation, which is specifically formulated for patients who need A, D, E, and K, and they're on a CFTR modulator and may have elevated levels of vitamin D, A, D, or E. This is the two formulations that are currently available on the U.S. market for the modulator formulations. We have the soft gel minis and liquid drops. Both of these vitamins only contain vitamins A, D, E, K, C, and zinc. The fat water-soluble vitamins have been removed from the product as compared to other formulations of MVW nutritional products due to the fact of their size as well as volume for the pediatric drops. Also, taste can be affected because the B vitamins do have allow for the taste of the liquid drops to be much more bitter than you would see with the regular ADEK vitamins. You will notice that the vitamin A content is higher as compared to the regular MVW products, and we'll be addressing the reason for that in the next slide. So when you look at what is actually happening, the vitamin A is the one that most patients are worried about because that is where the toxicities have been seen in the literature. So the vitamin A component of the modular formulations are higher than previous formulations, but the percentage of the retinol palmitate versus beta carotene is what is altered. And by having the more beta carotene, the vitamin A component had to be increased for that reason to get the more beta carotene in it. So in these formulations, there's a higher percentage of provitamin A, which is beta carotene, and a lower percentage of preformed vitamin A, which is retinol palmitate. When you look at the other MVW products, they usually have a percentage of beta carotene around 70 to 75%. In the modulator formulations, the percentage of beta carotene is between 90 and 95%, allowing for the beta carotene to be the primary driver of the vitamin A in the vitamins themselves. Beta carotene is a provitamin, meaning that the body has to convert it and activate it in order to be absorbed, to convert it to the retinol palmitate, which is the active form of vitamin A. So in the body, as you take the vitamin, there's a regulatory process via active transport and in the liver and in the intestines that the body converts the beta carotene to retinol palmitate and only absorbs what the body needs and gets rid of what it doesn't need, so leading to possible less toxicity in these vitamins as compared to ones that are more of higher percentage of retinol palmitate. Because retinol palmitate is the preformed vitamin A. It's active, it's absorbed with no regulation. And in these patients that we are seeing with being on highly effective modulators, there's something that happens with ETI in the body that allows for a higher, better absorption of the vitamins. And as they absorb faster, it may be crossing the blood-brain barrier quicker, leading to the body to react and have the increased intraocular pressure, intracranial pressure. That is a theory from what we've seen from the literature. And so that may be the reason. And by giving a higher percentage of beta carotene and less retinol palmitate, there'll be less chance of this actually happening. In these vitamins as well, there's lower vitamin E component. The percentage is 50% lower, so patients don't have to worry about higher vitamin E levels while on highly effective modular therapy. This is still up for consideration because you look at patients, some of the studies show vitamin E going up, some going down, or no changes. And so this is something that still needs to be elucidated and studied. But the reason being the lower amount was because initial studies showed that vitamin E levels went up on modulator therapy. The vitamin C is in there. We help assist with mucus viscosity, and the other water-soluble vitamins were removed mainly for size and taste, as well as recent evidence that questioning their need to be in for U.S. patients due to patients getting them from other sources in the diet. The liquid drops are a new product that just got released by MVW Nutritionals. They are available covered by the HealthWell CF Vitamin Supplement Fund, as well as they are being added to the enzyme value added programs. Currently, Pertzy, it's on the Pertzy Cares program, and the Nestle Live to Thrive is adding this product. It is available through Total Care RX, which supplies them for those two enzyme companies, and we are seeing them being added to other enzyme programs as well. They are available through the websites, and pharmacies can dispense them with a prescription or order them directly from MVW. The reason for these drops to be different, they are formulated specifically for the patients on a modulator formulation, but they differ from other CF-specific vitamins because of the taste, as well as they are a non-staining formulation of beta-carotene. So polysorbate 20 was added as a solubilizer to this product, which makes the fat-soluble vitamins water-soluble. And so thus it's the first less staining beta-carotene containing vitamin. It is still orange coloring, but when it gets on a piece of article of clothing, it can be washed out easily with just regular dish soap. They also taste good compared to other CF-specific vitamins due to the ethyl vanillin flavoring that is in it. It tastes with a citrus flavoring as well, with a citric acid. It has an orange creamsicle or orange Julius flavoring. So even though the volume is more of 3 mLs for the patient, the taste as well as the non-staining make this product favorable as an option for infants and younger children. One product that will be coming very soon on the MVW Nutritionals line in the modular formulation are the chewable tablets, which are expected to be released in Q3 of 2024. Our next clinical quandary is associated with the liver and hepatic issues that CF patients face. So currently, based on the CF annual data report, 12% of patients were prescribed ursodeoxycholic acid in 2022, or another name for it is ursodiol, for abnormal liver function tests or CF liver disease. Based on the new CF Foundation hepatology and liver guidelines that were published by Sellers and colleagues in end of 2023, ursodiol is no longer recommended for routine clinical use due to the fact that the studies show mixed results of efficacy of ursodiol. But in these patients who are on highly effective modulator therapy, we have several who are on CFTR modulators, and several of them may end up having a very common and serious adverse effect of the CFTR modulator of elevated liver enzymes, liver damage, or worsening of liver function. So the clinical quandary associated with this area is, now that we don't have a medication that is routinely recommended by the CF Foundation for the treatment of elevated liver enzymes or CF liver disease, what does one do if you have elevated liver enzymes or liver dysfunction in patients on CFTR modulators? So this is where an individualized approach, working with members of the CF team, care team, to figure out exactly what's best to determine a plan of action. If you have hepatologists or gastroenterologists, this is where you get them involved to first figure out and follow the guidelines, figure out exactly what's going on with the patient's liver, either be fatty liver disease or some other dysfunction, following by liver ultrasounds or other tests in order to determine exactly what's going on. For the modification of the medication, working as a team and following the package insert recommendations that are approved by the FDA to determine exactly what the best course of action to modify the dose based on what liver enzyme level they have. There is a new publication by Vonk and colleagues out of the Netherlands that does have recommendations of how to introduce ATI in patients with severe liver disease, following levels and doing therapeutic drug monitoring and checking their enzyme levels to introduce them so a patient can successfully be added on ETI therapy even though they have severe liver dysfunction. The final clinical quandary is associated with nutrition is CF-related diabetes. The things that we are seeing with CF-related diabetes are positive and may have long-term implications for our patients. With the nutritional approaches of patients being obese, as well as having increased weight issues, the current CFTR guidelines that were published in 2010 do not address this issue in terms of obesity because modulators were not FDA approved at the time. The recommendations for patients on CF-related diabetes are to have no dietary restrictions, to still have a high-fat, high-calorie, high-salt diet. New guidelines were published by international guidelines published in 2022 by Odie and colleagues actually addresses this, that patients who are on CF-related diabetes should be put on a low-fat diet instead of a high-fat diet. But what we're seeing, the positive things we're seeing with CF-related diabetes are issues with the blood glucose management. Hemoglobin A1C levels, numbers are going down. If you monitor via continuous glucose monitor or CGM, we're seeing better glucose management in those patients, as well as new studies showing insulin doses have decreased. But we have also seen in other studies conditions called metabolic syndrome that could be related more to type 2 diabetes. Patients have increased fat mass as well as cholesterol levels that have increased. So in this case, what do you do as a care team to help take care of these patients with nutritional CF-related diabetes issues? This is where, following the CF nutritional clinical quandary approach for diabetes, obesity, and diet outlined by the CF Foundation, looking at what other care members of the care team can do, specifically dietitians, pharmacists, endocrinologists, and the pulmonologists working together to figure out what would be the best approach to manage the patients from a nutritional aspect. From the glucose aspect and the glucose management, the positive things that we're seeing from the CFTR modulators are indication that CF-related diabetes may be able to be better controlled and managed because of being on a CFTR modulator. But this is where working as a team together to figure out the best approach for these patients is the most appropriate way to go. The care team managing together, looking at what needs to happen and how to manage it because of these positive indications, but also the long-term ramifications of what needs to happen, that possibly looking at long-term outcomes for the patients, that there may be other things that need to be addressed as we diagnose these patients earlier and they live longer. Thank you for the opportunity to present this to you as care teams and for you watching this presentation. There is one more that is in this by Dr. Kevin Epps looking at CF microbiology in cystic fibrosis. This is our contact information. If you have any questions, you're free to email us or call us at any time. Thank you for your time.